So hi, everybody. Nice to see you. So what we're going to do today is we're going to have some updates, which we're going to do after Grace's presentation. And I am really just delighted and very proud to introduce Grace Masters, who a lot of you probably know because Grace has been involved in the network and has been on a lot of our involved in in-person meetings and also the virtual meetings. So Grace is an MD-PH candidate at UMass Medical School. I'm Grace's primary mentor. That's why I'm particularly proud to be introducing her today. And Grace actually just successfully did an amazing job defending her dissertation, I guess about a month or so ago now. And although it still says she's an MD-PhD candidate, if she wasn't now in med school, she would have just been about to graduate or just graduated with her PhD. And she's in the clinical and population health research program at UMass Medical School. And Grace started with us a few years ago. And, Grace has really just done some really exciting, innovative work looking at, really thinking about how both access programs and also when we think about addressing mental health and substance use disorders in obstetric settings, how can we better integrate addressing bipolar disorder? That's really been the focus of Grace's work. And she's really done some wonderful, innovative work. And what she's going to be presenting today is one of the aims of her dissertation that focuses on specifically looking at how access programs can improve clinician capacity to manage bipolar disorder. And as you'll see, and as we'll have a discussion afterwards, there's some also really cool, I think, findings and implications for the mechanism by which access programs work that I think will come out of this. So Grace will present, then we'll do a few updates on some things that relates to the network, and then we're going to have a discussion. So she'll be presenting about half, then we'll have a discussion to think about, how do her findings and how does it implement, what is the implication for all of our access programs. So I will pass it off to Grace so she could start presenting.
Thank you so much. So as Nancy said, this is going to be a portion of my dissertation that I'm going to talk about today, specifically focusing on bipolar disorder and how access programs may be able to improve clinician capacity to manage bipolar disorder. So I know this group doesn't really need much of an introduction on the importance of perinatal mental health and substance use disorders, but I did want to spend a couple minutes just talking about why we should, want to focus on bipolar disorder specifically. So bipolar disorder affects 1 to 3% of the general population. However, there's a lot of evidence to show that during pregnancy and postpartum are when women have their highest risks for new onset or recurrence of bipolar disorder. In a systematic review that our group conducted, we found that the pooled prevalence rate of lifetime bipolar disorder in perinatal women was around 2.6%, which is on par with those estimates that I just cited. However, we also found in our review that the prevalence of mood episodes in perinatal women tended to be much higher than the rates of diagnosed bipolar disorder, with 20% of women having a mood episode at some point in pregnancy or postpartum. And these were not just, depressive episodes, but included hypomanic, manic, and mixed episodes. So these prevalence rates are really higher than what we would expect based on those diagnostic rates. Also importantly, we found that the prevalence of mood episodes in women with a history of bipolar disorder was close to 55%, which is quite high and higher than many prior estimates. So this is all just to say that bipolar spectrum mood episodes are actually fairly common in perinatal populations and are really an important consideration for us. Additionally, as I'm sure many of you know, bipolar disorder often requires more complex treatment than other perinatal mental health conditions. Continuous pharmacotherapy is almost always recommended for patients with bipolar disorder, even in pregnant or lactating patients. And discontinuation of pharmacotherapy significantly increases the risk for illness relapse in perinatal women. So it's a population that's particularly in need of access program help. The well-known gaps in access to mental health care are especially wide for those women with bipolar disorder. And clinicians across medical specialties, including those in mental health, are often hesitant to treat bipolar disorder in pregnant or lactating patients. And then, of course, many patients want to avoid all medications during this time as well, even if the recommendations are to continue. So solutions to bridge these gaps in care, of course, include innovative models like the Perinatal Psychiatry Access Program model. And so today I'm going to talk about 2 studies that we have done that provide some supporting evidence for this idea. And so I know that you all know about MCPAP for Moms, but since the services and kind of structure of the program are really critical to the research design, I just wanted to kind of briefly review the services that MCPAP offers. The largest proportion of services offered are the resource and referral services, where any clinician in Massachusetts that cares for perinatal patients or families can call and be referred to community mental health services, for example. Another component is that MCPAP for Moms provides education via training and toolkits on evidence-based guidelines for providing direct mental health care. And then MCPAP for Moms also provides real-time psychiatric consultations for providers and patients, or providers caring for perinatal individuals. And this is broken into phone consultations, where MCPAP for Moms psychiatrists speak with frontline clinicians to help them provide direct mental health care to their patients after an encounter. Or a MCPAP for Moms psychiatrist may see a patient for a one-time assessment. And then after that assessment, they may provide recommendations to that patient's provider to then help them treat the patient going forward. So overall, the goal is, again, to help frontline providers give direct mental health care to their patients until really longer-term psychiatric services can be secured. So the first study I want to talk about today is how, we're interested in if frontline clinicians are their perspectives on managing bipolar disorder in the obstetric setting, because this could be kind of controversial. It's a complex illness, and certainly not everybody is comfortable with it. And we also wanted to know that if clinicians have experience with an access program like MCPAP for Moms, how that might affect their perspectives, if that makes them, more or less ready to manage patients with bipolar disorder. So to do this, we sought to elucidate how MCPAP for Moms and potentially other access programs may impact clinician attitudes towards the management of bipolar disorder in the perinatal period, and to specify clinician level barriers, facilitators, recommendations to improving management. And really the kind of impetus behind this is that we all know MCPAP for Moms has been really well received by patients and providers alike in terms of helping to address perinatal depression. And so we just wanted to see if this extended to bipolar disorder as well. So to conduct this portion of the research, we actually did 3 focus groups with obstetric professionals to discuss their experiences and their perceived barriers, facilitators, and ideas for solutions for caring for perinatal individuals with bipolar disorder. And in the study, we defined obstetric professionals as physicians, midwives, nurses, and support staff. And then the focus groups were further divided into professionals with and without exposure to MCPAP for Moms. And this would really allow us to see, how perspectives would differ based upon whether they had ever, used an access program or not. And then our analyses were done using a modified grounded theory to identify themes in the data. And I'm happy to provide more information about any of the analyses for this or the other study if anyone is interested. And then additionally, prior to starting the focus groups, we asked the participants a series of questions kind of about their attitudes towards perinatal mental health generally. And one of those included how regularly they screen for bipolar disorder in their patients. And you can see here, excuse me, that participants with exposure to MCPAP for Moms were much more likely to say that they did regularly screen for bipolar disorder in their pregnant and postpartum patients. So I'm just going to go over some of the main themes that we found from our focus groups. And these will include sub-themes and selected quotes for emphasis. And I've color-coded the quotes so that the green quotes are facilitators and the red quotes are barriers. So the first major thematic group we identified was that participants with support of programs like MCPAP for Moms see addressing bipolar disorder as an important part of their role in providing comprehensive obstetric care. One provider that had exposure to MCPAP for Moms said, "I do think managing bipolar disorder is a part of our role in conjunction with psychiatry and other support services. It's multidisciplinary treatment, right? You need therapists, social workers, psychiatrists, OBs. We could all work together." Participants with exposure to MCPAP for Moms perceive their patients as being willing to be treated for bipolar disorder by their obstetric clinicians and are willing to talk about their mental health with them. Participants also reported that screening is occurring sporadically in places that do not have MCPAP for Moms exposure or access program exposure. And without adequate support, clinicians often reported seeing no point in screening for this illness. One provider without exposure to MCPAP for moms poignantly said, "Why screen for something we can't do anything about?" Participants reported that patient assessment for bipolar disorder is one of the most challenging parts for all obstetric clinicians, regardless of whether they had support of MCPAP for moms or access programs. Excuse me. However, participants did say that with support like an access program, clinician participants can be comfortable in treating patients with medications for bipolar disorder. So one obstetric provider with exposure to MCPAP for moms did say, "I'm a lot less scared to prescribe medications than I was probably before 4 years ago because I see that the benefit outweighs the risks. So I won't start somebody on a bipolar medication if I think they're bipolar. But if they've been on it and I call and I talk to a MCPAP psychiatrist and we talk through the case and they think it's appropriate, then I will happily prescribe it." Another major thematic group that we identified through these focus groups was that participants definitely think that systemic factors affect their ability to address bipolar disorder in the obstetric setting. Many participants reported that formal education about bipolar disorder in the perinatal period is really lacking, but that exposure to continuing education is very helpful. And this is something that access programs can and do currently take an active role in, so that's great news. One provider with exposure to MCPAP for moms said, "I've certainly been to enough lectures now where the topic is untreated depression, and here's all the bad things that could happen. So it used to be that no medications is best, and we're going to take people off of their antidepressants. And it's certainly not best. I feel like we have a different mentality about that." Many participants noted that there are relatively few mental health clinicians in their area, and this obviously creates barriers to care. But MCPAP for moms, other access programs, or collaboration with other professionals that have specialized mental health training can help to fill some of these gaps. And finally, many participants noted that coordination of care with outside psychiatric professionals remains a real challenge. Even this was reported whether or not they had exposure to an access program. One obstetric provider said, "I would tell the residents that pregnancy is the only condition in medicine that you get to freely discriminate against. So all these doctors just drop the ball and run when they see a pregnant patient. I'm talking about from the first pregnancy test, including your dentist." The last thematic group I want to touch upon are some of the recommendations for solutions that participants had in terms of better integrating the treatment of bipolar disorder into the obstetric setting. So many participants said that they could be made more comfortable in managing perinatal bipolar disorder through more educational efforts and easily accessible resources. Additionally, they noted that the incorporation of management of bipolar disorder in the obstetric setting may be facilitated by recommending efficient ways to integrate practices into already existing workflows. And finally, many suggested that employment of integrated care models and innovative delivery methods like access programs would be really helpful. Excuse me, something in my throat. So from this first study, we did learn that obstetric professionals are willing to provide mental health care to patients with bipolar disorder with adequate support, which is really exciting. We definitely saw that some of the suggestions that they provided are those that are already implemented in access programs, or are those that are, in the works of being implemented. So that's exciting as well. And in turn, all of this suggests that obstetric providers may be able to help bridge gaps in care that exist in the community for patients with bipolar disorder. So in that first study, we found some evidence that access programs may be seen as a resource to help clinicians to manage bipolar disorder. But it's also important to determine if access program utilization may actually build the capacity of these clinicians to do this work. That is to, provide direct mental health care treatment or bridge treatment for their patients with these illnesses. So to kind of get at some of this information, in the second study, we sought to characterize the extent to which MCPAP for moms utilization builds obstetric clinician capacity to give direct mental health care to patients with bipolar disorder after a MCPAP for moms encounter. So we wanted to explore the potential mechanisms here by which MCPAP for moms may be helping current providers to manage bipolar disorder, and potentially how the access program model may help others to do so. So in this study, our analyses were done using direct clinical encounter data from MCPAP for moms. And this was using data from the first utilization or the first encounter back in July of 2014, all the way through June 2020. And we did this using longitudinal models to determine, again, if increased utilization of MCPAP for moms was associated with increased frequency with which clinicians provided direct mental health care to their patients after an encounter with the program. So in our models, essentially the exposure was use of MCPAP for moms, so the total number of times a provider would interact with a program in a year. We also looked at, in addition to overall use, we looked at use of each of these individuals' services that MCPAP for moms offers. So just to remind you what those services are, these are the kind of the three major categories, and we looked at those that consist of like one-to-one interactions of a program specialist and a caller. So this would really, we consider these probably to be the most capacity building services. In terms of outcomes, we were looking at whether the provider agreed after an encounter to provide direct mental health care treatment to their patient, as well as if they agreed to treat more diagnostically complex patients over time, so such as patients with bipolar disorder. And we wanted to see if utilization basically would increase the rates at which frontline providers treated bipolar disorder. We also used this exploratory modeling technique to see if we could find subgroups of provider patterns of utilization to see if there are kind of certain patterns that may predict capacity building rates. And so I'll show that as well at the end. And again, if anyone is interested in more specifics on the methods, I'm happy to go into that. Sorry, just 1 second. So just to start, this is an overview of the over 1,000 individual providers in Massachusetts that have used MCPAP for moms at least once in this past 6-year study period. 80% of the users were identified as being from obstetric settings, and most were physicians. This graph just shows some descriptive trends over time of the rates at which frontline providers are giving direct mental health care to patients after a MCPAP for moms encounter. And I've kind of divided it out by diagnosis. So the black dotted lines shows direct mental health care to patients with any diagnosis. So the rates at which that's occurring. The red line is the rates at which direct mental health care is being given for depression after a diagnosis. And this is for bipolar spectrum disorders. So basically we can see here that clinicians are increasingly providing direct mental health care to patients with bipolar disorder with more utilization over time. And this is significantly increasing as well over time. When we look at the longitudinal models of utilization of providers, we do see some trends overall and by each service type used. So if we look first at use of resource and referral services, we did find that increased utilization of resource and referral encounters did yield a significant but modest association with the rates at which providers then gave direct mental health care to their patients after an encounter. And so this is again broken down kind of into the three major diagnostic categories I looked at. So any diagnosis, unipolar depression, and bipolar spectrum disorders. You can see that the effects are pretty similar across all three groups. Looking at the effects of or the associations of increased utilization of the phone consultations, or those kind of doc-to-doc calls, increased utilization again showed was associated with increased rates at which providers were giving direct mental health care to their patients after an encounter. And again, this was pretty similar across all three groups. And notably, it was greater than the effects that we saw with resource and referral utilization. And finally, when looking at one-time assessments with patients, increased utilization again showed an increased association with increased rates at which providers are giving direct mental health care to their patients after an encounter. And again, this was true across all diagnoses and was greater than either phone consults or resources and referrals. And interestingly, these one-time assessments exhibited the strongest association with providers giving direct mental health care to their patients with bipolar disorder after an encounter. So kind of overall, this basically suggests that increased utilization overall does predict increasing provider capacity. And specifically, these one-time assessments may be increasing provider capacity to treat more complex patients over time, like those with bipolar disorder the most. I also said that we did this kind of exploratory modeling where we looked at provider subgroups in terms of their utilization patterns. And we did find kind of 3 different subgroups. So there's some providers that, don't really use the program a lot and kind of use it at a stable rate over the years. There's some that kind of use it a little bit more, but also stable. And then there's the smallest group that, uses it pretty frequently and with increasing frequency over time. And so then we wanted to see, if these subgroups were then associated with different rates of kind of capacity. And we did, in fact, find that this to be true. So if we look at this kind of lowest group as the referent group, those providers in the kind of moderate and stable utilization patterns show a kind of 2-fold greater rate at which they treat patients with bipolar disorder after an encounter. And this kind of select group in this high and increasing utilization patterns show a much, almost 14-fold greater rate at which they're providing direct mental health care to patients with bipolar disorder after an encounter. So all this is kind of to say that there does seem to be, the patterns of utilization really are quite associated with the capacity that's built from the program. So the takeaways from the second study are that utilization of MCPAP for moms was associated with clinicians providing more direct mental health care to patients over time, as we would hope. But that included those with complex illnesses like bipolar disorder. And we found that increased utilization of one-time assessments with patients may be the most capacity building. And we found data to suggest that these subgroups may exist of utilization and may be associated with the degree to which utilization affects provider capacity. So thinking about these 2 studies together, I think it's really exciting because it really does provide evidence for the ability of access programs to help frontline clinicians provide direct mental health care to their patients with bipolar disorder. It's exciting even in and of itself that clinicians are willing to address bipolar disorder with support, since, this was not always a given. And another exciting kind of finding is that, overall utilization of MCPAP for moms was associated with increased clinician capacity, but type of service really does seem to matter. It does seem to matter if clinicians are using resource and referral services more, or these one-time patient assessments or doc-to-doc consults. So this is a really important consideration for MCPAP for moms and other access programs as they continue to expand and try and determine where to triage their resources. I didn't actually present this data, but we also did find that being a provider in a rural community was highly associated with increased capacity through the use of MCPAP for moms. And this was also exciting because I know there's a lot of access programs in the network that are in much larger states than Massachusetts, and have providers that are much more spread out and that are in rural areas. So it's promising to see that those providers are being well serviced as well. I know everybody's very familiar with this image, but I just wanted to kind of remind everybody where we're at and how much of the country we cover. So I think it's really important that we continue to explore and think about the mechanisms by which these programs work, so that we can continue to inform the care for many perinatal individuals. Some of the strengths of this work, just very briefly, are its contributions to an understudied area and population, use of multiple methodologies, and evidence for the access program model that can be built upon and more researched by hopefully other people in the network. There are certainly a number of limitations as well, including the fact that the perspective of our participants, particularly in the qualitative study, the first study that I presented, were fairly racially and ethnically homogenous. So we really do need to work hard to ensure that a broader range of experiences and viewpoints are captured in terms of perspectives on addressing bipolar disorder in perinatal patients. These analyses obviously stem from one particular access program, and it is in many ways unique. So it's important that we continue to see, how this may translate into other programs in other areas of the country. And I think, also very importantly, the formal link to patient outcomes is not clear based on this data. This is all kind of at the provider level. And so we do need to know, what is happening and if this is actually translating into better outcomes. Very briefly for future directions, one of my main takeaways from all of this was that bipolar disorder is important in this population, and it is really getting a short shrift. So I really hope that, more studies make a concerted effort to include bipolar disorder in their work. An emphasis on health equity and addressing structural determinants affecting access to care cannot be understated enough. And I'm really excited because Nancy's and Tiffany's newest PhD student, Esther, is going to be doing awesome work on this too. So hopefully that will be yet to come in a future meeting. I think there's ways in which this can be expanded to many other mental illnesses and substance use disorders. So this work can kind of be hopefully co-opted for some of that. And finally, I think it just will be really helpful to continue to explore the mechanisms by which access programs are working so that we can figure out how to best serve our patients. So this is my long list of acknowledgements to the Lifeline for Moms team, and especially the MCPAP for Moms team for all the amazing work that they do. And my references. Thank you very much.
Thanks.